Hello folks, welcome to our freshly online Unit 7 in Surgical Technology. This unit's on anesthetic agents. So the pharmacology learning objectives that apply to this unit are as follows: to analyze the principles of anesthesia administration, as well as to be able to explain the necessity of each component of anesthesia preparation for the surgical patient, to compare and contrast methods, agents, and techniques of anesthesia administration and preparation, and also to explain anesthesia complications and interventions. Moving on, here we have some resources and readings for you to complete in order to help you understand this material. So let's start off this unit by revisiting methods of administration. Now, as we know, medications can be administered to the patient, enter their body systems in several different ways. Intravenous is administration of a medication directly into the venous system. We see this in the OR anytime a patient receives medication through their IV. Inhalation is administration of medication into the lungs. The medication is inhaled and absorbed through that lung tissue. Intramuscular administration is medication administered directly into the muscle tissue through injection. Intrathecal is sometimes called spinal. This is when local analgesic like bupivacaine is taken past the dura mater and administered into the subarachnoid space in the cerebrospinal fluid. Think of intra as within and thecal as dura. So intrathecal administration is placed within the dura. Intrathecal administration will be below the L3, L4 space. So it's the third and fourth lumbar vertebrae, and will be somewhere around 1 to 2 cc's of medication. This results in pain control below that level where it's administered. Intrathecal administration does carry the risk of decreased blood pressure or bradycardia or a slow heart rate. In contrast, an epidural administration is when medication is placed in the space surrounding the dura mater rather than through it. There should be no access to the cerebrospinal fluid with an epidural administration. Think of epi as meaning around, so epidural means around the dura. More medications needed with an epidural, about 20 cc's versus 1 to 2 cc's if administered intrathecally. Epidural administration has a slower onset of action than the intrathecal, but the effects last longer. Also, epidural administration has a decreased chance of hypotension and post-dural puncture headache compared to intrathecal. Epidural administration can also be done at a higher level than L3, L4. Infiltration is when the medication is placed locally into the tissues. We see this when local anesthetic is used. The surgeon injects local directly into the tissues surrounding the operative site. Topical administration is when a medication is placed on the anatomy, usually skin or mucous membrane, and this is commonly seen with topical application of creams, gels, or ointments, etc. This is not an inclusive list of administration methods, but it is a good start to get us started with this unit. Now we'll talk a bit about some meds that may be given preoperatively. You may remember that we touched on benzodiazepines in our drug classifications unit. They may be administered to a patient in pre-op to help manage anxiety. They also have a sedative and amnesic effect. It's common for our patients to forget coming into the OR at all, or for the memory to be dulled for them. A patient with benzodiazepines on board may need less in the way of other induction agents when it comes time to go off to sleep for surgery. They aren't typically used alone for induction because high amounts would be needed. Remember that benzodiazepines don't provide any pain control. Some benzodiazepines that you may hear referenced in the OR are diazepam, or Valium, lorazepam, or Ativan, and midazolam, or Versed. These medications have a high lipid or fat solubility, which means that they're absorbed quickly and completely. Also, they easily cross the blood-brain barrier. There is an antagonist for benzodiazepines. The antagonist to benzodiazepines is called flumazenil. Barbiturates can also be used as IV induction agents. They rapidly induce anesthesia and are also rapidly eliminated. Commonly used for cases that have a shorter duration, like cardioversion. Barbiturates do have associated risks. These include respiratory and cardiodepression. Some other hypnotics that are similar and often grouped together with the barbiturates are listed on this slide. Ketamine is a hypnotic and amnesic that causes a dissociative state in the patient. They may appear to be awake, but they're not cognitively aware. It does make the patient extra sensitive to loud noises, so be very careful not to clank pans, mayo stands, basins, etc. No testing drills until the anesthesia says okay. No questionable conversation. Ketamine is also the only hypnotic that also has an analgesic effect. Now, remember, with all of these other hypnotics, we say no pain control, no pain control, no pain control. But with ketamine is different. It does have an analgesic effect. Propofol, which I apologize, I previously presented to you as a barbiturate, is actually not. It's just very commonly grouped as a hypnotic in with barbiturates. It's the most commonly used induction agent. This is that milky white medication. It has a milky white appearance and will cause the patient to be unconscious within 1 minute. That milky white appearance is due to it being an emulsion. If a patient has a soy or egg allergy, they should not have propofol because of substances that are used within that emulsion. It also commonly stings when it's going into the IV, and you may have heard anesthesia saying, this may sting a little bit as it's going in. That's totally normal and will stop in just a minute. The risks include bradycardia, hypotension, and apnea. Etomidate is a hypnotic agent that has a rapid onset of under 1 minute. This one in particular has less impact on the cardiovascular system, so they may choose to use this on patients that can't tolerate the increased risk of hypotension that comes along with other hypnotics. It's also a good choice for trauma patients already experiencing cardiovascular complications and can't tolerate any further decrease in blood pressure. Moving on now to analgesics, or those medications used for pain relief. They may be administered preoperatively for a patient who has pain before the procedure. Think about our trauma patients or those with painful pathologies. Morphine is an opioid from a natural source. Its onset takes from 2 to 5 minutes, but the effects can last up to 4 hours. There are some synthetic opioid options as well. They have varying strengths compared to morphine. The analgesics given to our patients in surgery will provide analgesia as well as some sedation. Some side effects may include vomiting and nausea, decreased respiratory functions, and decreased levels of consciousness. These are why it's important for these patients to be consistently monitored. The antagonist for opioid medications is called Narcan. We've learned about that in a previous unit as well. So I wanted to go a little bit further into opioids and those synthetic opioids that I mentioned on the last slide. From least to most potent, this is a list of common opiates, both natural and synthetic. And you can see from this list that they vary quite a bit in potency. All of them can cause respiratory depression. Here's a refresher from our previous units. Anticholinergics block the action of the neurotransmitter acetylcholine. This inhibits the transmission of parasympathetic nerve impulses, and what this means, practically speaking, is that anticholinergics will help to decrease mucus secretions of both the respiratory and the digestive tracts. Newer anesthetics seem to cause less salivation, so the need for pre-op anticholinergics has decreased. They can also be used to decrease cardiac response to the vagal nerve response that we see with manipulation of the bowel, the peritoneum, and the carotid. So remember that vagal nerve response ends up causing bradycardia in our patients. Some examples include atropine, glycopyrrolate, and scopolamine, which is also an antiemetic. Gastric agents are used to reduce the risk of aspiration and to minimize the effects of gastric secretions in the lungs if aspiration does happen. So by decreasing acid production, which we learned about in our drug classifications unit, there is less chance of vomiting. But if the patient does vomit and aspirate the contents of that vomit into their lungs, the idea is that the antacids have reduced the amount of acid produced, and there will be less respiratory damage as a result. You may recognize some of these brand names from your own medicine cabinet at home. Diphenhydramine, which is also called Benadryl, blocks histamines because it's an antihistamine, but that can also be used to reduce mucous membrane secretions. Let's look now at the inhalation medications used in surgery. Volatile anesthetic agents are share the property of being liquid at room temperature, but evaporating easily for administration by inhalation. Ideally, they'll offer smooth and reliable induction and maintenance of general anesthesia. They won't affect the health of the rest of the body. They won't smell bad. They'll be safe for all ages and for pregnant women. They'll offer a rapid onset and elimination from the body. They'll be potent, but also safe for the OR staff that are being exposed to them. Remember when we were talking about our patients breathing off their gases into the room? Ideally, they'll be cheap, but with a long shelf life. Ideally, they'll be easy to use, and they'll be stable, non-flammable, and safe for the environment, because those gases go somewhere, right? Now, none of these agents that we currently use are fully ideal. None of them tick all those boxes, although many of them have some of the desirable characteristics. For example, sevoflurane is pleasant to inhale and is rapid in onset and offset. It's also safe for all ages, but it's expensive and it's not as potent as some of the other options. Inhalation agents can cause cardiac depression with high doses. They're often used in combination with nitrous oxide, which is a colorless, odorless, and tasteless agent. It does build up in air-filled cavities, though, of the body, so it may need to be temporarily turned off during some procedural steps. Where I see this happening is during tympanoplasties, so that middle ear is a air-filled cavity within the body. So during the procedure, while nitrous oxide is being used, it fills with that nitrous oxide. So when it comes time for them to place a graft over that tympanic membrane, or place a tube even, they'll oftentimes ask anesthesia to turn the nitrous oxide off so that it doesn't blow their graft or their tube out once they put it back in there. The medications we've discussed in this unit so far have not addressed the fact that in surgery, we frequently need our patients to maintain relaxed musculature. We'd find it very difficult to perform procedures without blocking muscle contraction. Even though the mind is sleeping in general anesthesia, the body still reacts to stimulus, and that as we cut into and retract muscle and other tissue to gain access to something that's below it, the body will contract its muscles, trying to splint and protect itself. Neuromuscular blocking agents help us with this problem. There are two kinds, depolarizing and non-depolarizing. Depolarizing neuromuscular blocking agents bind to receptor cells in the muscle and cause little contractions under the skin called fasciculations. After the fasciculations, the muscle will remain relaxed because no more contractions can take place with the medicine continuing to block those receptor sites. There's only one depolarizing neuromuscular blocking agent in use, and it's called succinylcholine. You may remember that this agent is infamous as a major causative agent in malignant hyperthermia. There's no antagonist medication to the depolarizing neuromuscular blocking agent succinylcholine. So if for whatever reason they're given succinylcholine and react to that or decide that they don't want that on board anymore, they have to just let it wear off in time, which is one of the reasons why we have, as one of our responses to malignant hyperthermia, is to cut the medication, the succinylcholine, and to start giving 100% oxygen, trying to clear their system of it. Non-depolarizing neuromuscular blocking agents work a bit differently. They block the receptor sites in the muscle without causing initial contraction in the muscle. Therefore, non-depolarizing. Sometimes they use these agents before using succinylcholine to prevent the fasciculations. These meds may affect blood pressure and heart rate and heart rhythm. The antagonist to non-depolarizing neuromuscular blocking agents is neostigmine and androphenone. So there's an antagonist for non-depolarizing, no antagonist for depolarizing. Agents that are administered to minimize the possibility of post-op nausea and vomiting, sometimes referred to as PONV, post-op nausea and vomiting, in some patients. Pediatric patients are at a high risk for PONV. This has been explained to me in the past that kids come into the OR and are especially fearful or nervous, and this causes their gastric acid production to increase, and they're more likely to be nauseous when they wake up because of that. Girls are also 2 to 3 times more likely, though I have no explanation as to why. So, Raglan reduces gastric fluid volume. It's good for use with pregnant patients, at-risk patients, and those with a difficult airway, and emergency patients who are not NPO. Anapsine has sedative properties and an increased risk of fatal cardiac rhythms. The FDA recommends use of anapsine as a second-line option only. Zofran is the most commonly used antiemetic in the OR. Local anesthetic medication is administered to the immediate surgical site. It's either infiltrated into the tissue through injection or applied topically. The desired anesthetic effect is limited to a small area. The medication interferes with sensory nerve endings, blocking transmission of pain stimulus to the brain. Local anesthetic medications are commonly used, especially for procedures like small biopsies, hand and foot cases, skin lesions, etc. There are two classes of local agents, amides and esters. Amides are metabolized by the enzymes in the liver versus esters, which are metabolized within the blood. Let's take that a little bit further. Let's look at our amides a bit closer. Lidocaine, also called by the brand name xylocaine, is the most common local agent used in surgery. You've all probably seen it. It's fast-acting and rapidly metabolized, and the effects last between 30 to 60 minutes. If epi, or epinephrine, is added, it does increase the duration up to 50%. Lidocaine comes in 0.5%, 1%, 1.5%, 2%. A 4% solution is available, but it's used topically only. Remember that lidocaine can have cardiovascular effects. Ropivacaine is similar to bupivacaine, but it's less cardiotoxic. Bupivacaine, and I do want you all to practice saying these words. Bupivacaine. Stand in front of the mirror and say this word, bupivacaine, over and over and over again, because this is something that you guys do need to be able to say out loud, confidently, so that people can hear you in the OR. If you're stumbling over this word, take the time. You're at home, right? You're not coming to school right now. Stand in front of a mirror and practice this word and any other word that you're having a hard time pronouncing, okay? Bupivacaine. Bupivacaine is also called by the brand names Marcaine and Sensorcaine, and it's 4 times more potent than lidocaine. Remember, though, it does bind to cardiac muscle and it can be cardiotoxic, which means we have to keep the dosing in mind, okay? They're going to keep track of that very closely. Its effects do last longer than lidocaine, about 4 to 8 hours. You can see it in strengths of 0.25%, 0.5%, and 75% with or without epi 1 to 200,000. Mepivacaine is similar in potency to lidocaine, but with slightly longer duration, and it's used much less often. Exparel provides 72 hours of pain relief. This is a Marcaine or bupivacaine with Depafoam combo, which is why it is white in appearance. It must be refrigerated and must be used within 45 minutes after leaving refrigeration. So this is our ultra long-acting local medication. Most of these medications are vasodilators, but when combined with dilute epinephrine to cause vasoconstriction, it can slow absorption and bleeding. Labels of medications containing epinephrine will indicate this fact in red. Red caps and red on the label is a visual indicator that epi has been added. Okay, so a medication that has epinephrine in it will have red on the label. Epi should not be used for peripheral infiltration. Remember when I was talking about end site or end site peripheries? This is where I'm talking about, like, they will oftentimes choose not to use medication containing epinephrine when they're close to the earlobes, toes, fingers, nose, penis, the belly button, the nipples. And this is because of vasoconstriction. They don't want to vasoconstrict those end site capillary actions and damage the tissue. The most common mix is 1 to 100,000 or 1 to 200,000. Take warning, though, that it can come in strengths of 1 to 1,000. The patient would experience severe tachycardia and hypertension if this strength of epinephrine was injected. Therefore, epi 1 to 1,000 is only used in topical applications, and commonly we dye it a different color to reduce the risk of error in this way. So That was the amides, metabolized by the liver enzymes. Now let's look at the esters, which are metabolized by the blood. These are to be used topically only. Topically, okay? Esters are topical medications. We'll start with cocaine, which comes in a 4% or a 10% solution. It's administered on pledgets, cotton-tipped applicators, or sprayed on, never ever injected. This is a powerful vasoconstrictor and used primarily in nasal surgery. It's a controlled substance, and they make careful dose calculations per patient. Afrin, or neosynephrine, is more commonly used on nasal surgeries due to expense and because of fewer complications. Pontocaine is a potent, long-acting local. It's used topically before cataract surgery. And Ceticaine is a topical agent as well with rapid onset. They often apply it as a spray for bronchoscopy or for fiber intubation. The last thing we'll talk about in this unit is tumescent anesthesia. They inject a large volume of this dilute solution into the sub-Q tissue to facilitate fat suctioning before liposuction. Its use helps to reduce blood loss. They also use tumescent anesthesia prior to venous catheter ablation. Think laser or radiofrequency treatment for varicose veins. It can help to provide some pain relief and act as a buffer to reduce damage to the surrounding tissue. A common tumescent solution is 1% lidocaine, epinephrine, 0.5 to 1.5 milligrams per liter, and injectable normal saline. Sodium bicarb may also be added to increase absorption and shorten onset time. Glucocorticoids may also be added to reduce inflammation and scarring.